There he is. Hi,
All
Dr.
right.
Wang.
Hi,
There we
everyone. Sorry
go.
about that.
Yeah, no worries. I just said, what would a live thing be without a tech
Yeah.
issue, right? Oh, so here we go. So I just did an introduction of myself, Dr. Wang, and so now I would like to introduce you. And we have a lot of questions already. We got some questions via email previously, prior to the call, and so I have them ready to go. But for everybody who is watching, please, what we're going to ask you to do is type your questions in the chat, and then we will go through them one by one. I will read them aloud to Dr. Wang, and he will just verbally answer them. Okay, does that sound like a plan?
Sounds good.
All right. So first, why don't I let you introduce you? Tell us who you are and where you are.
All right. Thanks, Kristen. Happy Saturday to everyone. Hope people are enjoying a nice fall Saturday wherever you are. So I'm in the San Francisco Bay Area. I'm a hepatologist at the University of California, San Francisco, and I run the UCSF Porphyria Center. I'm happy to be here for me this morning on Facebook Live for everyone, with everyone, and happy to answer any questions that you guys have. And from past experience, we oftentimes run out of time, and I'm happy to get the unanswered questions for afterwards and write out some answers that I can then give back to Kristen, and Kristen, you can redistribute to folks.
Great. Thank you, Dr. Wang. That's wonderful. Okay, so let's dive right in. The first question is for acute porphyria. And it is, I was weak and symptomatic from childhood, had attacks since puberty every month and more. Now I have flare-ups from every small effort and more so during the luteal phase of my cycle. I get super weak and faint and have radiating pain. Givosiran helps a bit and reduces the intensity of the flare-ups. But the question is, what can I do to get stronger and more active?
Yeah. So really good question. I think before I answer that question, I'll just to make sure that all of us are on the same page in terms of our understanding, and also just to tell a little bit of how I think about acute porphyria attacks and what causes the symptoms. So in acute porphyria attacks, and this is true across all of the different acute porphyrias, acute intermittent porphyria, which is the most common one, varigate porphyria, hereditary coproporphyria, and then in the very rare ALA dehydratase deficiency porphyrias. And all of them, what is common is that during acute attacks, when people are experiencing symptoms, for example, is the symptoms that were just described, the symptoms are caused by abnormal accumulation in the body of two chemicals. The first one is called delta aminolevulinic acid, and the second is called porphobilinogen. And these two chemicals are part of the production pathway of heme that the body makes. And in all of the porphyrias, including the acute porphyrias, there's a partial defect in the body's ability to make heme, and as a result, we abnormally accumulate some of these intermediates. And in all of the acute porphyrias, ALA and PBG, that are abnormally accumulating, and these two chemicals damage nerves in the body. And it's nerves everywhere in the body, and it can certainly cause weakness and numbness, and fatigue, as well as abdominal pain and a whole host of the other symptoms that I think folks are very familiar with. So when patients with acute porphyria experience symptoms, right, there are two potential ways that the symptoms can arise. The first is during an acute attack, because of high levels of ALA and PBG, those chemicals are actively damaging the nerves. And as the nerves are damaged, then you feel those symptoms, okay? In patients who have had acute porphyria attacks since their childhood, people who've had recurrent acute porphyria attacks, or sometimes in patients who have had even just one attack, but that is very severe and very prolonged. That attack can result in more permanent neurologic damage. so that even when the levels of ALA and PBG are normal, they have already, the body has cleared the excess ALA and PBG. If the nerve is damaged and is not allowed to heal or is permanently damaged, patients can also experience symptoms, sometimes even when the levels of ALA and PBG are not elevated. Okay, so when a patient is having an acute attack, generally, the way that we treat it is by lowering the production of ALA and PBG, and that's how panhematin works. Or if in Europe or other places in the world, heme arginate is we give the body heme, and it tells the body to stop trying to make heme, and the body stops accumulating higher levels of ALA and PBG. It takes the body a couple of days to get rid of the excess ALA and PBG that has built up during an attack. So usually the symptoms don't go away until day 2, day 3 of heme infusions. Okay, and we generally, in those cases, once an attack is stopped, if that attack has not been persisting for many, many weeks, then the symptoms should go away. Now, with the more severe the attack and the more severe the nerve damage, it may take longer for patients to fully feel back to normal. So many patients will say that after a severe attack, it might take them a couple of weeks for them to fully get back to normal because it takes the nerve some time to recover. Okay. Now, in patients who've had many attacks in their lifetime, right, eventually the nerves can become permanently damaged. Okay. And in those patients, you can have symptoms even without high elevations of ALA and PBG. Okay? And in those cases, lowering the level of ALA and PBG, for example, with givosiran, we're trying to lower those levels, that will help with the acute attack symptoms that are caused by a current high elevation of ALA and PBG. But we're not sure if things, medications like givosiran or panhematin can have an effect on, healing nerves that have been permanently damaged when the body is no longer actively accumulating high levels of ALA and PBG. All right. So I would say in this case, the first thing I'd want to know is, are the levels of ALA and PBG still elevated currently when you're experiencing those symptoms? Because if they are, then that would suggest that, hey, we can do something about lowering the high levels of ALA and PBG that's currently happening in your body. And I would expect for you to experience some improvement in your symptoms. That could be done with hemin. That also maybe the dose of givosiran needs to be adjusted, or the interval needs to be adjusted. Okay, we have some patients, and generally these are patients with frequent recurrent attacks who have had many attacks in their lifetime, mostly attacks that haven't been treated, that then still have chronic neurologic symptoms, and these symptoms feel very similar to the symptoms that they had during their acute attacks, because it's the same nerves that are damaged, it's the same nerves that are sensitive. And so it could be really difficult to distinguish symptoms from residual nerve damage to those symptoms from an active acute porphyria attack.
Okay. So for this person, in the idea, just a lifestyle, like in between attacks, getting healthier and stronger, are there any specific recommendations, or is it just to be able to lead a healthier, active lifestyle?
Yeah, I would say in this case, I think suppressing ALA and PBG elevations, make sure that they're no longer elevated really at all, to give your nerves the best chance to heal. And then probably you need time. It can take nerves many months to fully heal. Okay, and that's assuming that there hasn't been really permanent neurologic damage. I will say that if there is already permanent neurologic damage, it's very difficult to resolve those symptoms. We're talking about getting in the realm of other medications that can be used to treat, neuropathy, medications like, for example, gabapentin, other ones, but their effectiveness is really limited.
Okay. So how often, I have a related,
one other thing, Kristen, I just mentioned that this is, this is the reason why we really want to push for increased awareness of acute porphyria. And want to also push for for access to testing, and then also treatment. Is, these kinds of, permanent neurologic damage can be prevented in acute porphyria patients. But the way to prevent it is to identify and make the diagnosis early and treat the attacks early. And then now that we have a medication that can prevent acute attacks from happening pretty effectively, is that the goal should be that we avoid having any patient develop permanent neurologic damage.
Okay. Okay, I am going to switch over to, wait, my question was, how often should someone with acute porphyria have their labs done?
Right. So patients who are getting, so let me start from the more severe patients, and then we'll go down to patients who have really sporadic attacks, or patients who have never had attacks. Okay. So if you're having recurrent acute attacks, you're getting regular treatment every time that you are, right before you get a dose of panhematin or hemarginate, right before you get your monthly or more infrequent dose of givosiran, please get a random urine for ALA and PBG. Okay. We need to get as many data points, biochemical data points of ALA and PBG as possible is really helpful, and that's the only way we can personalize and tailor your treatments. Okay, so I would certainly get ALA and PBG from a random urine before each treatment. Okay, and then for those patients who are, whenever you're experiencing symptoms that feel like acute attacks, I would get urine for ALA and PBG. Okay, for those patients who are not experiencing any attacks, let's say you're a known genetic carrier because you have a family member, you've done genetic testing, but you've never experienced symptoms, I think get a baseline level so you know that what your baseline levels are, and then probably I would say maybe once every 5 years go get a urine ALA and PBG, just so that we can track it, that we'll get an idea, because people will develop, these attacks are not present all the time. I think probably even patients on this call, like the last patient said that her attacks really started during teenage years. Some patients, the attacks start in their 20s. Some patients have it later on in life. Tracking their ALA and PBG levels once every couple of years can sometimes give you a little bit of heads up into when your disease course may be changing.
Okay, great. Okay, I'm going to switch over to a question from a person with PCT.
Okay.
So the question is, well, it says, I have PCT. I was diagnosed about 4 years ago, and in the past 2 years, I've only had to have 2 phlebotomy treatments. Are there any reports of PCT going into remission? And is there a clinical drug I can take to help with sun exposure? And a big thank you at the end of that question.
Okay, all right. So PCT, Porphyria cutanea tarda. PCT is the only one of the porphyrias that can develop in the absence of an inherited genetic mutation. Okay, and the reason for that is because the enzyme that is partially defective and responsible in Porphyria cutanea tarda is an enzyme called uroporphyrinogen decarboxylase. It's an enzyme that works primarily in the liver, and patients who have other kinds of liver diseases. Some of the more well-known ones, chronic hepatitis C, although that is a far less common cause now because our treatments to cure hepatitis C are so effective, but alcohol use, people with inherited defects in iron metabolism, who have iron overload, for example. All of those patients can develop Porphyria cutanea tarda without having inherited a mutation in this UroD enzyme. Okay, so Porphyria cutanea tarda, the best form of treatment, there's 2. I would say there's 2 very effective ways to treat PCT. So the first way is what has been just discussed, which is phlebotomies. So it turns out that in PCT, iron accumulation in the liver is really important for inhibition of the UroD enzyme. And so phlebotomies work really well to normalize the iron levels. And then an anti-malarial treatment, chloroquine or
Mm-hmm.
hydroxychloroquine, also works. And we use it at much lower doses than what is used to treat malaria. That medication works slightly differently. It doesn't lower iron levels in the liver. It actually gets rid of the porphyrins that are accumulating in the liver first, that then sort of, then distribute out to the body and cause the skin symptoms. So both of those medications are really effective for treating PCT and then preventing the blistering skin lesions.
Okay.
In terms of medications to use that allow patients to have more sunlight exposure, we actually don't generally recommend that as a first-line treatment for PCT,
Mm-hmm.
primarily because therapeutic phlebotomies and chloroquine treatment are so effective that you can get into long-term remission for PCT and not need to have sunlight protection. Okay, I should mention also that for those patients who have PCT because of an underlying liver disease,
Mm-hmm.
just treating that underlying liver disease will cause the PCT to go into remission. All right. So for example, patients with PCT who have chronic hepatitis C, if you cure that patient of chronic hepatitis C without having to do any phlebotomy, so give that patient chloroquine, the PCT will go away and it won't come back. Okay. So for PCT, really, I would recommend treating the underlying liver disease if that was the cause of the PCT, or if you have hereditary inherited PCT, then either therapeutic phlebotomy or chloroquine, and then you shouldn't need to have, you shouldn't need to practice more sunlight protection.
Okay.
Right? But if you really had to, right, for whatever other reason, and then we can, this will apply also for patients with the other cutaneous porphyrias, erythropoietic protoporphyria, patients with CEP, congenital erythropoietic porphyria, or patients with, variegate porphyria, hereditary coproporphyria, where we have a harder time lowering the porphyrin levels in the body. Those patients really do have to practice sunlight avoidance primarily. So that's with, long sleeve clothing, wide brim hats, gloves if you need to protect the back of your hands. Okay. There is now a medication that is available that can give you a little bit more barrier protection on the skin. And so this is the medication afamelanotide or SCENESSE, which is really only approved for patients with erythropoietic protoporphyria, for EPP patients. But the way that this medication works is by stimulating the pigment producing cells in the skin to make more pigment. It makes you more tanned, and that gives you a little bit of barrier protection. As far as I know, that medication is not approved for PCT, nor is it approved for CEP or variegate porphyria or hereditary coproporphyria. So that medication really currently is only available for patients with EPP. But that would be kind of, the only medication that I can think of that would allow you to have a little bit more sort of barrier sunlight protection, but really doesn't unfortunately apply or is not available for patients with PCT. But what I really want to emphasize is that for PCT, you shouldn't need that. The treatment itself for PCT is really effective, and we can get you to the point where you don't need to practice sunlight protection.
Okay. Side note on PCT, historically it's been known as the most prevalent type of porphyria. Given how treatable it is, do you think it's still the most prevalent porphyria?
It is, and it is the most prevalent porphyria because it's the one porphyria that can develop without having inherited the mutation, right? And so, and because now a much larger population of people who have just underlying liver disease can be at risk for developing PCT. So I expect even going forward that PCT will continue to be the most prevalent porphyria, even as we are getting a better understanding of how frequent mutations in some of the porphyrias are actually present in the general population. So for example, people with acute intermittent porphyria, it's still true that patients with symptomatic acute porphyria probably, the prevalence is probably close to 1 in 100,000 people or thereabouts, okay? But the prevalence of mutations in the acute intermittent porphyria gene is actually about 1 in 1,500 people, okay? So that makes the number of mutation carrier to be much higher than what we previously thought. It's easily close to, it's probably 70 to 100 times more prevalent in terms of mutation carrier. That doesn't necessarily mean that there is 100 times more people with symptomatic acute porphyria than previously thought, but it does tell us that as we're learning more about these diseases, we're even learning more about how prevalent and how common these diseases are. But having said all of that, I still think that PCT will continue to be the most common of the porphyrias going forward.
Thank you. Okay, next question. We are going to switch over to CEP, congenital erythropoietic porphyria. And the question is, what is best to use on blisters related to CEP exposure or sun exposure with CEP?
Yeah. So CEP actually shares some similarities with Porphyria cutanea tarda that we just talked about, as well as varicate porphyria and hereditary coproporphyria, in that some of the porphyrins that are accumulating are very similar. They all have high levels of uroporphyrins, and they all develop these blistering skin lesions, but only on sun-exposed areas of the skin. Back of the hands tends to be most common, face, scalp, neck, really anywhere that gets sunlight exposure. The main difference with congenital erythropoietic porphyria compared to all of those other cutaneous porphyrias that cause blistering skin lesions is that in CEP, the levels, especially of uroporphyrins, are generally much higher in the body than PCT or any of those other ones. And partly as a result of that, there is very poor wound healing in CEP, even much worse than in PCT. Okay, so even patients with PCT will say that their wounds take these blisters when they rupture and then they get unroofed. They will take a long time to heal, and they will scar, and that takes a long time to go away. But those patients, they very rarely, if ever, develop infections in the open blisters. But in CEP, the levels of uroporphyrins are so high that it probably inhibits the immune system in some way. And so those patients are at very high risk of developing infections in their open wounds. And then those infections take a long time they actually can worsen. And so patients with CEP can eventually actually lose parts of their soft tissue because of chronic infections that can happen in their hands, that can happen on their nose, in their ears, even in eyelids and other places. So it is really important that you practice very careful wound care of all of your blisters, and especially the open blisters. Okay, antibiotic ointments can be very helpful and may be really important. I highly recommend that all patients with CEP have a dermatologist that they can see on a regular basis, who can help them with prescriptions of medications, antibiotics to treat the infections if they're there, as well as additional resources for wound healing and wound care for the blisters.
So you mentioned the antibiotic ointment is that an over-the-counter, or is that a prescription for someone?
There are over-the-counter antibiotic ointments, but really this is for CEP patients. I really highly recommend that you establish care with a local dermatologist, because these infections oftentimes can be with different kinds of bacteria and sometimes antibiotic resistant bacteria. I wouldn't just treat them put some over-the-counter antibiotic ointments on and think that that's enough to cover it. I think that, depending on the response to the initial wound care, you may need additional, sometimes you may need even, wound debridement and other things to help clear out those areas. So the problem is that there is, with continued infection and an inflammation, for example, on the part of the hands, back of the hands, there can be poor blood supply to that area. And so then it's really difficult for the body to naturally fight those kinds of infections. And that's why you may need stronger antibiotic treatment for that. And sometimes you might need systemic antibiotics. And then in the worst case scenario, you might even need wound debridement to remove some of those infected necrotic areas to allow the underlying tissue to heal.
Okay, so the message there is have a local dermatologist or a healthcare professional to support you.
That's right.
Yeah. Okay. There's another a CEP question that I'd like to address now, and it is from a mom who has two children with CEP, and they have both received bone marrow transplant. They are currently doing great and they are thriving, but the mom's question is, what are the odds of them possibly reverting back to before they had the transplant?
Yeah. We have not seen that. There's been no reports of reacquisition of congenital erythropoietic protoporphyria symptoms. So with a bone marrow transplant, as long as the bone marrow transplant is successful and that the transplanted bone marrow stem cells take hold and can repopulate and are responsible now for generating all of the new immune cells and for CEP, especially the red blood cells in the body, then the new red blood cells that are being made no longer has the mutation in the Euro-S gene, and there's no more accumulation of uroporphyrins. And so the disease will not recur.
Okay, great. Thank you. Excellent answer. Okay, we're going back to acute porphyria. The question is, I have AIP, and as of late, I've been having issues with cortisol levels and alkaline phosphate levels. They're saying that the alkaline is telling them that I have some bone breakdown, so I'm super confused, especially about the cortisol levels. Have there been any studies, or is there anything that you recommend that I have my hematologist try or to look at? This patient is, or person is, receives panhematin every 4 weeks for 4 days and givosiran every other month currently.
Okay. So the question about cortisol levels is really interesting. So cortisol is a hormone that is produced in the body, and very recently there was a international Porphyria conference in Spain just 2 months ago, and this was the first time I met an endocrinologist from the UK who has been working on inherited diseases that involve actually low cortisol levels. Gave a presentation and showed some, I think to my knowledge, the first time that patients with acute porphyria attacks, especially during attacks, can have lower than normal cortisol levels. Okay. Now, that's the first time that that I have seen this kind of data, but it suggests that perhaps during acute attacks, that the body's during an acute attack, your body your body is under stress. Patients, for example, know that your heart rate generally is up, your blood pressure is up. In that kind of stress state, we generally expect the body to be producing high levels of cortisols, right? To as a response to that increased stress. It's a normal response to stress in the body, and it's possible that in perhaps a subset of patients, the acute attack itself may affect the cortisol producing cells in the adrenal glands, leading to lower cortisol levels. That's we don't really know. We don't know enough about this issue. I think at this point, what I would say is, if you have low cortisol levels, you should probably get an endocrine evaluation by the endocrinologist to check to see if there are any issues with, for example, your adrenal glands that's responsible for producing cortisol levels. The other thing is that it would be really helpful to track your cortisol levels, especially during your cycles of attacks, to see if it correlates to when, for example, your ALA and PBG levels may be higher or your acute attack symptoms may be higher. Okay. If that's true, potentially changing and having a little better control of your ALA and PBG levels may, may affect your cortisol levels. So that's about cortisol. Now, the alkaline phosphatase is a separate issue. During acute porphyria attacks, about 15 to 20% of the time in the middle of an acute attack, patients may see some mild liver inflammation. Generally, that's reflected as an increase of the levels of ALT and AST in the blood. Alkaline phosphatase is usually not elevated. So alkaline phosphatase is an enzyme that generally we see as elevated when there's signs of liver inflammation that is related to the bile ducts in the liver, okay? And there's no correlation, as far as I'm aware of, with bile duct injury in acute porphyria attacks, okay? Alkaline phosphatase can also be elevated if there's bone breakdown. That is far less common than liver causes of increased alkaline phosphatase. So in this patient, I would first check to see that you can check for alkaline phosphatase that's bone specific, okay? To look to see if the bone-specific alkaline phosphatase is the main component of your increased alkaline phosphatase. If it is not, you should get an evaluation of your liver. I'd probably start with an abdominal ultrasound to see if there's anything going on in the bile duct system. But in any case, I generally think of both of those potential causes in the liver as well as in the bone with either bile duct issues or bone breakdown as pretty independent and separate from acute porphyria attacks. So I'd make sure that you don't have a separate issue happening either in the liver or in bone.
Okay. And for this, but we may have a follow-up, just offline question to follow up on this one.
Sure.
Okay. Dr. Wang, is there any expected timeline for FDA approval for bitopertin for EPP?
Yeah. So bitopertin is a drug that's currently just finished phase 2 clinical trials, and there are plans for a phase 3 clinical trial to start soon for this medication. This is a medication, it's an oral drug that is being used in erythropoietic protoporphyria patients. And the way that it works is it's a small molecule that inhibits a transporter that brings into a cell one of the starting material for making heme, and specifically the amino acid glycine. And in the phase 2 clinical study, the results show that bitopertin lowers the protoporphyrin 9 levels. That's the porphyrin that is abnormally accumulating in EPP, as well as X-linked protoporphyria, XLP. It lowers it on average about 40% in the patients. And it concurrent with that, patients are seeing benefit in terms of sunlight tolerance. Okay, so that medication, it's still, I would say probably minimum, a couple of years away from FDA approval. So generally, the process of getting FDA approval for a medication is you have to go through first, the preclinical development, and then it needs to be tested in healthy volunteers to make sure that it is safe. Those are phase 1 clinical trials. Phase 2 clinical trials, again, are to test for safety, but now on a larger group of patients, and then also to determine the safest dose to use. And now we start to get some information about efficacy, how well it works. So that's where things stand with bitopertin. With the phase 3 clinical trials that's about to happen with bitopertin, we'll finally be able to formally answer the question of effectiveness. How effective is this drug in lowering protoporphyrin 9 levels? How effective is this drug in improving symptoms and sunlight tolerance in patients with EPP? That phase 3 will likely take at least 1 year from the time that it starts, probably even a little bit longer, because of the time that it takes to accrue all the patients for the study, and then the time that it needs for all the patients to go through the, this is going to be likely a double-blind randomized clinical trial. And then it takes time for the data analysis to occur. And then if at the end of that process, probably minimum a year and a half, 2 years, then if the drug has shown really confirmed to be effective, then you start the FDA approval process, which can easily then take another year or longer. So We're a couple of years away still from bitopertin, but it is the results, I would say, thus far are quite encouraging.
Great. Terrific. Thank you. I have another question with EPP. And it is, thank you, by the way, for the education on the drug development process. We try to get that information out there, and especially what's going on within each porphyria, but it's always a great reminder. Okay, EPP question. I have EPP. My iron level is very low. I tried a little iron infusion a month ago, the worst time of my life. I couldn't go out of my house for 2 weeks. I am very light sensitive, even in my house. I'm very tired, and it's starting to affect my heart. And this is from a patient in South Africa who doesn't have access really to knowledgeable physicians.
Yeah, yeah. This is a question that we get a lot, and which is, what's the relationship between iron levels and severity of symptoms in patients with EPP as well as XLP? And I think this is still an area where we don't have clear answers to this. We have had patients with both EPP and XLP who commonly have some level of iron deficiency, and it sounds like in this patient, the iron deficiency is a little bit more severe, perhaps already also leading to anemia, which then leads to its separate set of symptoms. And we've had mixed results when patients have tried to correct their iron. In some patients, I think perhaps a little bit more common in patients with EPP than XLP, they've had some improvement in their symptoms with iron supplementation. But then in others, it's been a little bit more likely in XLP patients than EPP patients, where the symptoms get worse with iron supplementation. Okay, so iron deficiency with the more iron. So iron is the main limiting factor actually for red blood cells when they decide whether or not to make more heme. Okay, so on the one hand, you can imagine that lower levels of iron in the body kind of limits the red blood cells production rate of heme and hemoglobin, and perhaps that might lead to a slightly lower accumulation of protoporphyrin IX and perhaps better, a little bit better symptoms. And that if you supplement the iron, give a patient more iron, now you allow the red blood cells to rev up and make more heme, and you might accumulate higher levels of protoporphyrin. But that's not, but I think that's only happening in some patients. So for this particular patient right now, we don't have clear enough data to have definitive recommendations of how to treat iron deficiency in a patient. What I will say is that if your iron deficiency is severe enough to cause anemia, okay, I think that has to be treated because, as the patient mentioned, anemia, low levels of red blood cells can have sometimes even more dangerous, effects on the patient than high levels of protoporphyrin. Anemia causes additional stress on the heart for patients who already, for example, have early stages of heart failure that can push those patients into more severe heart failure. So if you have clinically significant anemia, the iron deficiency needs to be treated to at least resolve the anemia. It does mean that for you, during that period of time, your EPP symptoms may be worse. And you may just have to, unfortunately, practice more strict sunlight avoidance until the anemia is corrected. Okay. If you don't have clinically significant anemia, you just have a little bit mild iron overload, I think it's reasonable to try probably with just, oral iron pills to see how your body responds. And then, see if your symptoms get better, your EPP symptoms, if your prodromes come on faster or slower with iron. I think it's a reasonable way to try it, but just be careful as you do it.
Okay. Great. Thank you. And to that patient, you are not alone. If when you're going through that, the worst 2 weeks of your life, reach out. We can connect you with other patients and support you in that time. Okay, I like to trick you, so we're going back to acute porphyria for the next two questions. And the first one is, I am a 29-year-old female that was diagnosed with AIP in 2022. My attacks are triggered by my menstrual cycle. My husband and I would like to start a family. Any experience or thoughts about if pregnancy is safe or what type of game plan I should have?
Yeah, yeah. So, in general, patients who are experiencing acute attacks, the attack frequency generally is lower during pregnancy. And some patients, I think most of the time, patients even report less severe attack symptoms during pregnancy. And mostly we think this is because your hormones, sex hormones, and primarily progesterone, stop cycling during pregnancy. And that's probably why in those patients, the attack frequency is lower. Okay, so if so pregnancy is safe. And on top of that, hemin treatment with panhematin, as well as hemarginate, is also safe during pregnancy and safe for the fetus. It's also safe if you're breastfeeding. Okay, so for those patients who are on givosiran for acute porphyria, that's more of an open question because there is very little information out there about whether or not givosiran is safe for the fetus, as well as safe in breast milk. As of now, I only know of one patient, and this has not been reported in the scientific literature, but I only know of one patient who was on givosiran through the pregnancy. And that patient gave birth to a normal, healthy child. And as far as I know, about a year, we're about a year plus out, that child is still doing well. But that is the only case that I'm aware of anywhere in the world where there's been, use of givosiran during pregnancy. For now, we still recommend all of our patients on givosiran to stop givosiran if you are thinking about getting pregnant. And because givosiran likely sticks around for quite some time in the body, I've been recommending my patients to stop givosiran for a minimum of 3 months, up to 6 months before attempting to get pregnant. Okay.
Thank you.
Yeah, this is an area that will need active investigation over the next couple of years. But until we have more information, my recommendation is to, stop givosiran before you try to get pregnant.
Great. Thank you. Okay, another AIP question. Can AIP or VP cause lower leg, ankle, and foot swelling? This is a new symptom for this patient that just does not seem to want to go away.
Yeah, so generally, swelling in the body, really anywhere, is not typically reported as being related to acute attacks. Okay. Again, as I mentioned earlier, acute attacks we think are caused by high levels of these two chemicals that damage nerves in the body. And so you can get all kinds of symptoms related to nerve damage, abdominal pain, nausea, vomiting, changes in bowel habits, weakness, numbness, increase in heart rate, blood pressure, and mental status changes, central nervous system can be affected. But generally, when I think of swelling, we're thinking about things that are more related to blood vessel and flow of blood vessel, of fluids across the body. And generally, that's not really affected during acute attacks. Okay. Now, this I would want to know, is swelling on one side of the leg or both sides of the leg? One-sided asymmetric swelling is very atypical and points to more of a local issue that really should be checked out. Bilateral lower extremity swelling, it is pretty common, gets more common with age, because your veins' ability to bring blood flow back against gravity up to the heart decreases with age. And so, some little level of lower extremity swelling does become more frequent. But the things that I worry more about with lower extremity swelling are heart issues. Is the heart's ability to bring blood back to the heart as well as pump out to the rest of the body. So I might want to make sure that you get these other things checked out, the much more common causes of swelling, because I don't think that this is, I think it's very unlikely that it's related to your acute porphyria. And maybe I'll just mention here that I think in general, I think this is probably especially true for patients with the acute porphyrias, that because this is such a rare, it's a rare disease, but it's a disease that causes such a wide range of manifestations that both on the part of patients, but also on the part of other healthcare providers, may have a tendency to attribute all kinds of other health issues that occur to acute porphyria. Okay. And I just want to make sure, just emphasize that acute porphyria patients can still develop the other more common causes of health problems, right? You can develop heart issues that's totally independent of acute porphyria. And this is even true if you have symptoms that are somewhat related to an acute attack, right? Acute porphyria patients can develop appendicitis, totally separate from an acute porphyria attack, right? You don't want to miss that. You don't want to miss a gallstone episode that becomes a more dangerous, life-threatening thing. So still, you need to make sure that you rule out the more common things, even if you have a confirmed diagnosis of acute porphyria.
Great information. Thank you. Okay. Another AIP question. Is there anything I can take for treating my perimenopause symptoms other than HRT, which is not safe for AIP?
Yeah. So I would first say that, hormone replacement therapy, I wouldn't say that they are absolutely contraindicated in patients with acute porphyria. Okay. I would say that, estrogen by itself, estrogen supplements by itself, their risk of inducing a porphyria attack is not that high. It's mostly hormone replacement that also includes progesterone that is more dangerous, more likely to induce an attack. Okay. Second, the risk of inducing an attack also depends on your own risk for having attacks, right? A patient who just has a genetic defect, has never had an attack, or a patient who's had one attack in their entire lifetime, perhaps an induced attack because they were taking a well-known medication, an antibiotic or an anti-seizure medication, for example. Those patients have probably a pretty low risk of having either a spontaneous or another induced attack. And so a medication that has a lower risk of inducing an attack may very well be safe, right? And then the last thing I will mention is acute attacks can be treated, right? Now that depends on if you have access to panhematin so that we can treat you for the attacks, right? So in this particular case, perimenopausal symptoms, it is a risk-benefit analysis. How severe are your postmenopausal symptoms, right? How high is your risk of having an acute porphyria attack? How readily accessible are treatments for acute porphyria attacks for you, right? So I will want to weigh all of those things together when deciding whether or not it is safe for me to take any hormone replacement treatment to help treat perimenopausal symptoms. But just in general, estrogen supplementation is it can induce attacks, but its risks are not that high.
Okay, great. Thank you. Is there any correlation noted between EPP and Hashimoto's disease?
Right. So Hashimoto's disease is an autoimmune issue that targets cells in the thyroid. I am not aware of any connection between erythropoietic protoporphyria, which primarily affects and manifests in red blood cells in the bone marrow and their ability to make heme, because they accumulate high levels of protoporphyrin 9. And I'm not aware of protoporphyrin 9 damaging thyroid cells. I'm also not aware of protoporphyrin 9 levels inducing an autoimmune, immune system to induce other kinds of autoimmune issues. So I do not know. I don't think that there is any connection between EPP and Hashimoto's.
Great. Okay. Thank you. Back to acute porphyria. Have psychological changes been noted with givosiran? I'm experiencing severe psychological issues, usually within days of my injection. Been taking it since 2017. I have fewer and fewer intense attacks in general. I've also had increased neuropathy pain with the psychological changes. All of these symptoms have started within the past 6 months, and this patient was diagnosed with AIP in 2009.
Okay. So I'm not aware of reports of increased psychological symptoms, mental status changes on givosiran. And I also have not heard of this type of timing of occurrence of symptoms, several years into treatment with givosiran. But I do not want to rule out the potential that givosiran was responsible for this, because we are still really pretty new in terms of our, we're just getting into kind of more long-term experience with givosiran. So this kind of information actually would be really helpful for us to track. And there are actually, so just as a sort of a separate plug, if you allow me, there are two ongoing longitudinal clinical studies where we can track these kinds of long-term symptoms on givosiran, and this also applies for patients who are on other treatments. For example, afamelanotide for EPP, as an example, another medication that's only recently been on the market. So with the Porphyrias Consortium, we have a long-term longitudinal study for the natural history of the Porphyrias, and we are collecting treatment information and side effect information as part of that study. So I highly encourage all patients who are on this Facebook Live session to reach out to, you can reach out to Kristen. She can connect you to a local, especially in the United States, and if you're in Europe, one of the EPNET sites, and there are other porphyria research sites around the world, so that if you are willing, you can enroll in one of these more longitudinal clinical studies so that we can collect some of these drug safety information. The company Alnylam, who produces givosiran, has a separate study called the Elevate study that specifically also tracks long-term history on all patients with acute porphyrias, and they're especially interested in patients who've been on givosiran for a long term. Okay, all right. So to go back to for this patient, I would suggest in your case that you check your ALA and PBG levels. There was recent, again, this International Porphyria Conference from 2 months ago. There was significant, quite a lot of information that was presented about long-term use of givosiran and frequency of dosing for givosiran. In Europe, for example, there's more and more data out now that on average, once a patient has been on givosiran for around 4 years or so, that many of those patients in Europe have been safely extended their givosiran intervals to as long as 6 months, and a few patients have completely stopped taking givosiran without recurrence of their acute attacks. Now, it yet remains to be seen whether or not over the long run, the ALA and PVG levels will again come back up, and if those patients will ever redevelop acute attacks. But in this part, in this particular patient's case, since you've been on givosiran for quite a number of years, I'd want to know how well you're controlled biochemically in terms of ALA and PBG. I would be a little surprised if the new onset of neuropathy symptoms are because you're having higher levels of ALA and PBG if givosiran has been on board, okay? So there may be something else that's happening. I don't, I can't rule out side effects from givosiran, but we've not seen any neuropathy side effects from givosiran. And maybe the thing to do here is to consider, hey, can we safely extend your givosiran interval and see if that helps in terms of your mental status symptoms, as well as these other neuropathy symptoms. But all of that is predicated on good biochemical control. So as I mentioned earlier, really, the more frequently you can test for ALA and PBG, certainly for you before every single dose of givosiran would be very helpful here.
Okay, great. And thank you for mentioning the longitudinal study. It is, and thank you to folks who are on here who are already participating in the LS. And again, for anybody that would like to participate in this longitudinal study, they can contact us at me or anyone from the UPA team at info@porphyria.org. Okay, Dr. Wang, do you have time for 2 more questions?
Sure.
Okay. Next question is, could a porphyria attack affect your vision?
Short answer is yes. High levels of ALA and PBG can certainly affect the nerves that innervate the eye, and patients can have blurry vision. You can have even visual hallucinations. It's related to that, as well as your central nervous system's processing of your visual input.
Okay, great. Thank you. And this one is an acute porphyria. I am 46 years old. I have had AIP, for it's European. I've had AIP for 4 years, and I have had Lupron injections for 2.5 years and Givlari for 1.5 years. I have a lot of symptoms from days 7 to 15 of my cycle each month. Very bad hot flashes, severe chills, fatigue, weakness, dark urine. Do you think it's due to Lupron, menopause, or is it that I'm fighting a porphyria attack differently since I've had Givlari? This is a pretty big question.
Right. And I think actually the only way to answer that question is to actually check for urine ALA and PBG levels. And in this case, the way that I would do it is, as I mentioned before, check your ALA and PBG levels right before your dose of givosiran. That gives you an idea of how well you're controlling your ALA and PBG levels at the very end of your cycle, right? Now, since you're having symptoms in a specific period of time, I would actually check for ALA and PBG right around that time to see if the ALA PBG levels are higher right around that premenstrual period. And if the ALA and PBG levels are higher, then that means that your symptoms, I would say then your symptoms are due to higher levels of ALA and PBG. Now, rather than using Lupron, I would suggest in that case, perhaps adding a dose of, if you're in Europe, heme arginate right around that time to further suppress ALA and PBG levels, okay, to see if you can control it. You can also play around with frequency of, the timing of givosiran to see if you can get better control right around your perimenstrual cycle period. If, on the other hand, the ALA and PBG is totally normal and well suppressed even during that period of time, now we're talking about, okay, this is other symptoms on the body, physiological symptoms due to your hormone levels, which then will require different kinds of treatment that I probably would go talk to your gynecologist about that to try to come up with a regimen that may help with that.
Okay, terrific. And that is all we have time for today. Dr. Wang, thank you so much for your time, your talent, your expertise, and most of all for focusing on porphyria in your career. You're just wonderful and giving your time so freely to the patient community and responding to these questions on a Saturday. We just can't thank you enough. You're wonderful.
You're very welcome. Happy to do it anytime.
Terrific. So for everyone who is watching, we do have a few questions that are left. We will get responses to them from Dr. Wang after the live session. And we will post this video. It will be available on the Porphyria Together Facebook group page once this is over, so people can go back and watch it. We do plan on doing our live events regularly, so keep sending your questions, and based on our community need, we'll schedule it as often as you would like. You can always ask your questions in Porphyria Together. You can contact us. We are a resource for you. Or you can send them to info@porphyria.org. We're in touch with Dr. Wang and the other experts from our scientific advisory board every single day. So we are glad to help. A couple more things. We do have small group discussions, Connect Up, for various types of porphyria or special interests. We also have an ambassador program where we have one-on-one calls with trained ambassadors. So there's friends within the community. Just folks, just know that you are never alone in this. You've got us and you've got each other. And we have our expert physicians. So thank you for joining us today, and enjoy the rest of your Saturday. Thank you.
Have a good weekend, everyone.
Bye, Dr. Wang.
Bye-bye.